Okay, so number one, module number one, let's talk about the pelvis. The pelvic arteries are derived from the aorta, which bifurcates around L4, L5, or L5S1. It bifurcates into the common iliac arteries, which are retroperitoneal structures. And it is important to know about the pelvic arterial supply because it does affect the supply to the lower extremity, particularly in chronic arterial occlusive disease like in atherosclerosis. In other words, if you block any part of these arteries here or these arteries here, there are certainly collateral paths that will come into play, and we all need to understand what those are. Additionally, if you have injuries to any of these, like dissection, for example, then other arteries from the internal iliac of the pelvis will come into play and feed the leg. So we must be aware of all of these possibilities. This is a view from Netter and I use a lot of Netter drawings because my foundation of anatomy understanding was based in Netter because that was the first book I think I ever bought in medical school. So most of these are going to be from Netter, but not all. And I think for the most part, he did a very good job, and his predecessors have done a good job. His successors have done a good job in updating these when there needed to be corrections. But essentially, you have the aorta, which is going to bifurcate into, for example, a left and a right common iliac artery. And then you're going to have this external iliac artery and an internal iliac artery. The external iliac artery is going to move anterior as it attempts to leave the pelvis and go under the inguinal ligament to become the common femoral artery. Before it goes under the ilioinguinal ligament or Popart's ligament to become the common femoral artery, it's going to give off some critical blood supply to the inferior epigastric artery. This is another artery called the deep circumflex iliac artery. And these two arteries are important collateral paths when you have occlusion here because blood supply will come down from above elsewhere and they will be paths to feed the lower extremity. Additionally, the internal iliac artery is a major collateral route. As you can see, there are many branches of the internal iliac artery. It divides into a posterior division and an anterior division. The anterior division is predominantly responsible for supply of the pelvic viscera, and the posterior division, its largest branch is the superior gluteal artery here, and this will go on to supply the gluteus maximus muscle. There's also an important collateral path that comes from the Ileal Lumbar, which is the first branch off the posterior division. So there are three main branches off the posterior division, which include the Ileal Lumbar, the lateral sacrals, and the superior gluteal artery being the largest branch. The Ileal Lumbar artery will anastomose or collaterally fill from lumbar arteries that come off the aorta. All right. The anterior division vessels, there are many of them. We're not going to talk about a lot of them right now, but it's important to note that an obturator artery goes through the obturator canal, which is right here. And if you look here, it has a collateral vessel, which fills from the inferior epigastric many times, and that's called the Coronal Mortise, which is a variant arterial sort of route that goes from the obturator over the superior pubic foramen, is the largest artery in the body. It bifurcates at around L5, L4, L5. Here's L4, here's L5, here's S1. It gives off the right and left common iliac arteries. The common iliac artery then bifurcates into two vessels. One is the external iliac artery here, and another is the internal iliac artery. Now, the blood supply of the leg and thigh and foot are derived largely from the external iliac artery. And so when we have a blockage here or an occlusion, we call this an inflow problem to the lower extremity. An outflow problem would be something lower down, like, for example, in the superficial femoral artery. And I'm talking mostly about atherosclerosis. But the external iliac artery doesn't have as many branches as the internal iliac artery, and that's because its purpose is really just to bring blood flow to the thigh and lower leg. It does give off two important vessels. One is the inferior epigastric artery, and another is the deep circumflex iliac artery. And the inferior epigastric artery is important because if you have occlusion of the external iliac or the common iliac, this vessel can fill the lower extremity by way of an important collateral path that we'll see in a minute. The deep circumflex iliac artery is usually not important, but sometimes it is for when you have blockage and occlusion. But other times it's important in trauma because it can be injured with iliac wing fractures. All right, moving on to the internal iliac artery, which is right here. The internal iliac artery bifurcates into the posterior division and the anterior division. The anterior division is responsible for supplying the pelvic viscera, namely the internal pudendal artery here, and which is responsible for maintaining potency, and other branches, for example, to the bladder and to the rectum. But there is an important branch that is the obturator artery, which comes off here and it goes to the obturator canal. And the obturator artery is another important branch should there be occlusion of the external iliac artery, but patency here, then this can come and the obturator will fill the femoral artery from collaterals, which I'll show you later. There's also a variant which is called the Coronal Mortise, which is a artery that lies over the superior pubic ramus and connects the inferior epigastric artery to the obturator artery right here. That is an important artery that is injured sometimes in orthopedic operations, and we certainly see it in pelvic trauma, and we just saw a bleed from one the other day, in fact. So that's the anterior division right here of the internal iliac artery, and then there is the posterior division, which is this vessel here, the posterior trunk of the internal iliac artery, which gives off three main vessels. The first is the Ileal Lumbar. The Ileal Lumbar will ascend and anastomose or collaterally fill from lumbar arteries. Then you have the lateral sacrals, which are going to move medially and supply the sacrum. And then the last is the superior gluteal artery, which is large and has a characteristic sweep through the greater sciatic foramen. We'll see more of that in a minute. So all these vessels are, a little bit outside of the scope of this talk, but I've tried to highlight the important ones for collateral flow to the lower extremity should there be occlusive disorders like atherosclerosis. These are the main branches angiographically. This is the internal iliac artery here, and we have a posterior division, which is very, very easily identified because of the superior gluteal artery that has its characteristic sweep. Other easily seen ones are the Ileal Lumbar, which is the first branch off the posterior division, and then the lateral sacrals here. The other ones are sometimes difficult to distinguish, but this right here that goes down goes through the top of the obturator canal, and the obturator foramen is the obturator artery. And this will collaterally fill from branches of the profunda to supply the leg, which I'll show you in a minute. There also is a longer one, which is the internal pudendal artery that is coming down here as well. And that is going to supply the perineum and the penis and the vagina. All right, I'm just going to quickly go through these. So the external iliac artery, as I mentioned before, just to review, I just want to make sure we're all clear on these. You have the common iliac artery, and then you have the internal iliac artery. And the point of the internal iliac artery with lower extremity flow is collateral formation in the setting of atherosclerotic occlusive disease, usually in the chronic situation, but you can certainly have collaterals develop spontaneously in the acute situation. Then you have the external iliac artery. Notice we don't have many branches, and then we come to the inferior. I have a cat and a dog running around our room right now. Inferior epigastric artery, and then this obturator branch that can come off, and this is a variant called the Coronal Mortise. The external iliac artery and the common iliac artery can also be important in the pathogenesis of venous disorders. So in this case, there's something called May-Thurner syndrome, which is something we should all be aware of, which is this condition in which the right common iliac artery compresses the left common iliac vein. Because of, if you go back to your cross-sectional anatomy, you'll see that the right common iliac artery lies directly over and can squish the left common iliac vein, particularly if there are osteophytes or any degenerative change there. So, and other things certainly can cause compression of the iliac vein. It is a retroperitoneal structure. Those include tumors and lymphoceles and urinomas and lymphadenopathy and all these sorts of things. But for the purposes of this discussion, May-Thurner syndrome is the right common iliac artery compresses the left common iliac vein. And I don't think any discussion of the pelvic arterial anatomy is complete without discussing May-Thurner syndrome. So here you can see that this left common iliac vein is squished because of this right common iliac artery. Here's an example of May-Thurner syndrome in a 55-year-old female with left lower extremity swelling. Here we have the aorta. We have a large kidney, single kidney here. And as we scroll down, we see, let's go back up. So we see the aorta here, all right? And we have the IVC. And as we scroll down, we see that this is the right common iliac artery, and it is going to compress the left common iliac vein, which is going to come out here. And here it just squished by right behind the right common iliac artery. So that was, let's go back and look at it. Here it is here. This is this squished left common iliac vein. You can't even see it. But it is so flattened by this artery that it has resulted in a filling defect in here. So if I compare this common iliac vein on the right with the left common iliac vein, I notice that there is an intrinsic filling defect, and that is thrombus because this patient has a DVT. Here it is. You compare both sides. Here's an artery. Here's an artery. Here's a vein. Here's a vein. They should all look, the veins should look the same and the arteries should look the same. And here you can see that there's a complete filling defect in the left common iliac vein, and it is different if you compare it to the right common iliac vein. Here it is again, external iliac vein and internal iliac vein with that thrombus. So let's go back up. You can see that's expanded, thrombus-filled common iliac vein, and it even extends down into bifurcation. Left internal iliac vein, left external iliac vein. Here it is here, external iliac vein, internal iliac vein, major DVT here, iliac DVT right here. Compare these two sides. This is an iliac vein, external iliac vein with thrombus in it. There's the external iliac vein on the other side without thrombus in it. Also, it extends below the inguinal ligament into the femoral vein, and so we have an iliofemoral DVT, goes all the way down here, all the way down the leg, and there's some edema. You can see that there's a little bit of swelling and soft tissue edema. All right, going all the way down into the popliteal vein. All right, so that's an example of May-Thurner causing stasis as a result of compression of the iliac system, arterial system, which has resulted in DVT. What about in atherosclerosis? So let's go back to just the arteries. We're not talking about veins anymore. This is a patient with claudication, so meaning that they have pain with walking that is related to arterial insufficiency. And that pain is reproducible after they walk a certain amount of distance or walks a certain number of steps. And claudication is usually, we talk about it in terms of its location, if it's calf or thigh or butt. And in this case, this patient, I believe, had calf claudication. But what we have here is, this is a volume rendered study, CT scan, where we see the vessels kind of displayed out. And let's go through this. So think about what's going on and we can talk about it. Here you can see that there's a narrowing here. This is the left common iliac artery. This is the right common iliac artery, and there's nothing connecting these two. And then there's a spider webby pattern of vessels that are important collateral paths. And you don't see the same thing on the other side. So I'm looking at this and I'm thinking, I think this patient probably has a common iliac, an external iliac artery occlusion. And in fact, this patient does. So I did an angiogram and I see that here's a catheter. It's a pigtail catheter with markings on it so that each one of these is 1 centimeter. So we use that when we're thinking about sizing an artery for a stent or a balloon. And we have, this is the common iliac artery. This is the external iliac artery. Here's the internal iliac artery. Here's the superior gluteal artery doing its characteristic sweep through the roof of the greater sciatic foramen. Here is the left common iliac artery. Here's the left internal iliac artery. Here's the left external, and boom, it's out. So we see that it tapers down, and then we just have some collaterals. We're not sure where those are, what those are called yet, but let's keep looking. So if I've shot from above with a pigtail and contrast is directed down, I can also do angiograms from below, which is what we've done here. And we see all these collaterals. So this is the bottom of the external iliac artery, and this is the top. So we have a segmental occlusion of that vessel. Here it is. Let's look at it again. All right, so blood flow comes down. It doesn't go through the external iliac artery because it's occluded. Some of it is going to go through the internal iliac artery, and here it is. This internal iliac artery is large and abnormal when can you compare it to the other side. And it's a little bit more tortuous. And there's these huge collaterals, so you know that they're playing a role. You see these crazy-looking serpentine collaterals here are playing an important role. So blood flow goes down. Because of the external, it's occluded. It needs to find an alternative way down to the lower extremity, so it's going to go through the internal iliac, and it's going to go through these collateral paths that are going to fill usually the obturator artery down to the medial circumflex femoral. So it's going to happen right here. This is this collateral path. This is the obturator coming down, giving off this artery that's going to feed the leg. And then, of course, we have this crazy-looking vessel here, which is the inferior epigastric with its tortuosity and has branches on the lateral anterior aspect of the abdominal wall, and that's going to be an important collateral path as well. So we can come down from above and cross this critical stenosis. Here you have a little trace of a vessel here, which is possibly a muscularis branch in the artery. And then we connected through a sheath and a catheter. We were able to connect and go through this soft cheese-like occlusion of the external iliac artery all the way down to the left femoral artery. And then we were able to line it with stents. You see the collaterals are gone. The collaterals are no longer necessary. And now there's inline flow to the left lower extremity. So here it is again, all these collaterals. Here's the, there's this critical stenosis here. And then we angioplasty it, and then we put the stent across, and everything looks good. Okay, so that's kind of an approach to an external iliac lesion. It's amazing how well people collateralize when they have those kinds of lesions, and it's also very rewarding to fix those using endovascular techniques. So usually what we're trying to do is recanalize a vessel, meaning trying to pound our way through an occluded artery and then open it up with wires and catheters and balloons and stents. How about this patient? This is another interesting example of a very important collateral path in the setting of aortic occlusive disease. This patient had buttock claudication and impotence, and you can see that if I go through this volume rendered CT, here's the superior mesenteric artery, here's the abdominal aorta, and you can see that it starts to taper shut right here. And then you start to see the iliac arteries here. We're not entirely sure, but here is a better view. So the aorta stops abruptly, and then there's patency down here at the bottom of it, and this is the right common iliac artery. I'm sorry, the left common iliac artery, and this is the right common iliac artery, and it goes through its normal branching pattern. But there's more vessels here because there's important collaterals that are helping fill the lower extremity. So if we look at that, we're going to see some very critical vessels come in from here. And this is the inferior epigastric artery. And remember on that last angiogram, I showed you some crazy collaterals that were serpentine. This is what they are. This is the inferior epigastric artery anastomosing with the superior epigastric artery, which is going to come down from the internal mammary artery. And this becomes a critical path, a critical collateral path in the setting of occlusion of the abdominal aorta. All right, that's called mid-aortic syndrome. And there's a number of causes of mid-aortic syndrome. What we see in the United States is usually atherosclerosis, but there are other vasculopathies like giant cell arteritis, Takayasu's arteritis, fibromuscular dysplasia, neurofibromatosis, Williams syndrome, and others like radiation and rare things. These are typically treated with bypass, but not always. There's certainly ways to fix these endovascularly as well. This is the pathway that we talked about. This is called Winslow's collateral path, which is from the internal mammary artery. It goes, the internal mammary, in this case on the right, is going to give off a musculophrenic branch to supply the diaphragm, and the superior epigastric artery, which is going to have these collateral serpentine vessels, and they are going to anastomose or collaterally fill from the inferior epigastric artery. So in the setting of occlusion here, blood flow will come down this way, that's this path, and then fill the legs that way.